This before we go to the modern teaching methods, one major concern is we have to improve our anatomy workstation, which is very lagging in our setup. So first thing I would like to tell is we have to upgrade anatomy dissection workstations, which is not at all considered in India particularly. So advanced dissection table systems, main is it should contain enough lighting and digital features, which is very important for the beginners to do the dissection without even proper lighting, and what they are dissecting should be coming in the monitor adjacent to the table. So these are the modern dissection tables in University of Toronto. When I visited, I have entered the dissection hall also. I was surprised to see their dissection tables, each having the monitor adjacent that is fixed to the table. So we should upgrade to the modern dissection tables, which is very important for the first year teaching. And one more thing is which is neglected in dissection hall is formalin fumes, exhausts and lighting, which is not at all even taught in our Indian medical schools. So after considering this anatomy workstation improvement, we can improve this dissection method along with supplementary resources. We all know that it is coming now, Anatomage table. So Anatomage table, it is we should have dissection adjacent to that Anatomage table. Students should be taught in both. For some time, 10-15 minutes, they should be explained in Anatomage table, then they should be brought to the actual dissection, then they will understand really better. There are many studies, I have quoted one study, and we have to concentrate on teaching the students with 3D anatomical models, which is we are not at all in line. So 3D anatomical models have taken anatomy teaching elaborately in the Western medical colleges, medical universities. So we all know first we have to get the data from computer, that CT, MRI, and even these 3D anatomical models not only for teaching, it should be in the surgery department also. So these are the 3D printed anatomical replicas. You can see it is very difficult even to differentiate the cadaver or the replicas. So we can't tell this as models, we can call this as replicas. So this is Professor McMillan from Monash University, Australia. He has suggested that without dissection, their students are doing equally well with the 3D replicas. So even many studies are there. These are the recent studies they presented in this 25 conference, American Association of Clinical Anatomists. This Catherine, she has done this study with both. She has exposed a particular set of students to cadaveric hand dissection and 3D printed hand models. She has compared pre and post test scores. They are equal. So this is again another study in the same conference. 3D printing of brachial plexus. So 3D printed anatomical replicas are not only helpful in anatomy, we all know that it is very essential in surgery department also. Even we all know that only in India our departments are compartmentalized. We are separate and you are separate, anatomy is separate, surgery is separate. In Mayo Clinic, both in UOT, I have seen and I have heard all they work together, anatomy and surgery. This is the Mayo Clinic surgery OT having this replicas. This is the YouTube link. We can see how they first depend on the anatomist to prepare the 3D model of that particular region for that particular surgery on that particular day. So the next thing is coming to the plastinated specimens in anatomy teaching, which is invented by von Hagen. He is from Germany. This technique was introduced in 1977. He is the pioneer in the plastination, and he has taken patent for all this. He He has 3 institutes in 3 countries. They are supplying all over the world. And this is the technique. In this, there are 4 steps: fixation, dehydration, then integrating the resin into the specimens, then curing, making it hard. So this technique was mainly that Van Hagen's, he has adopted it, and he is doing wonders in the medical education. He is supplying all over the world, that institution. So we can see Warwick Medical School, UK, they teach anatomy only with plastinated specimens from 2008. So this is Professor Peter Abraham.
Here is the sheet of the muscular part of the diaphragm, dividing the thorax above from the abdomen.
These plastinated specimens are dry, odorless, and it can be handled by the students and faculties very easily without exposure to formalin.
There's a huge bag here that's got a hole cut in it. Well, that bag is in fact the stomach, and we've cut a little hole in the anterior wall.
So with this, we can aid our dissection teaching, and apart from aiding our dissection teaching, further methods we can implement as art and creative approaches. And I took the perceptions of these students. They agreed that 98% of the students agreed that increased their subject confidence and drawing in histology. So body painting is from 1999, nowadays coming to Indian medical colleges, that Den Acker et al. Is the first person to use body painting, mainly important in surface marking. So these are the pictures, the same 23 batch did in our college. And this is that poster I have presented in Anatomy Connected 25. Again, these students, our batch of students, 95%, they agreed that this increased their subject confidence. So this is the anatomy glove learning method, which was introduced by Annie Agar at UOT in the very early part of 20th century, before 2010. She was trying, she is the physical therapy educationist. She was trying to teach hand anatomy. She was trying to teach with normal gloves and ink. Then that ink was spreading. So she thought of adapting some glove with skeleton of the hand. I saw in the ASCA conference the glove method, how they taught with traditional teaching method and glove method. Both are equal, both scores are equal. So we have to adopt so many new methods in teaching anatomy apart from dissection. So instead of all these doing histology, Rangoli, body painting for one day and leaving, that is not the concept. I heard in this another conference, anatomy escape room, that I heard in last year. Anatomy escape room, what is anatomy escape room? Then I was seeing what they are telling. That should be adjacent to the dissection hall. If they are dissecting, for example, brachial plexus for 2 days, 3 days, they are standing there. And they should be given some other place so that they can draw the brachial plexus. They can just make with thread the brachial plexus. So that much space should be given to them, and these methods, art and creative methods, should be implemented in everyday teaching of anatomy. So these are the anatomy escape rooms present in the Western universities. So there are again another study to confirm this. This is that this game method or escape room, how it is comparing. So we have seen the art and creative. Last part of is tools and techniques to facilitate effective cadaveric dissection. So anatomy lab should have adjacent ultrasonography lab, or that is the common in Western countries. You can see this is the one paper by the UG student in USA UG student, ultrasonographic variants of the suprascapular notch. So they every day, whatever you teach liver, they have to again see the living ultrasonography of the liver. That is the method adapted in the foreign countries. And we all know that virtual reality and augmented reality, not only in anatomy, it should be there in all the branches of our medicine to improve our student learning. So this is virtual reality, which is adopted in Taipei Medical University in Taiwan. And especially this is the recent study which was conducted in 52 second year students to teach embryology. They tell this SHSU University, they feel that at least to teach the complex subjects in medicine, we should be able to get the benefits of virtual reality and augmented reality. So this is another study, augmented reality, how it is an updated interdisciplinary study conducted. So you can see how the students should know the facial muscles, how they should be able to replace the facial muscles in the position, this study. So to conclude this blended learning, it is not purely dissection method what we are adapting. We should adopt a blended method, dissection and also digital learning activities. As I tell, it is not only in anatomy, it should come, the day should come in all the branches. So this is that this Professor Richard Tunstall from Warwick University, I heard his webinar in the last anatomy day. I was surprised to hear him say that in Warwick University, no dissections, no lectures, we produce world-class surgeons. So I was surprised, then I searched this, what is their teaching of anatomy. This is that their facility, $4.2 million is invested in anatomy in Warwick. They have plastinated human specimens, all realistic training world, dedicated clinical spaces, immersion, AR and VR suit. So last part of this, apart from the tools, there should be a system of, as I told, we should be integrated in teaching anatomy. So integrated teaching, I recently saw this one paper, cadaver-based endoscopy training for undergraduates. This is from Creighton University. So that interdepartmental teaching should be not only for the postgraduates, but also for the undergraduates, will improve their learning. So again, this is cadaveric neurosurgical procedures from University of Central Florida. Here the preclinical 31 students were able to do ventriculostomy procedure along with the surgeons. So like this, they conduct student interest groups so that to train even the UGs in the various surgical procedures. So to conclude, modern anatomy teaching methods, our NMC has adopted this CBME from USA and UK, but it has not updated the anatomy teaching methods, and they are asking only cadavers in the anatomy in Indian. They have not adopted this ultrasound radiology labs in anatomy, facilities for 3D printing, and facilities for plastinated specimens and AR and VR labs, which are present equally in US, UK. These competencies have been only adopted by NMC from them. So to conclude, there is a call for resource allocation to strengthen anatomy education in par with super specialty departments, and it is funding should be there, not only simply age-old dissection tables and cadavers. So it is no longer sufficient to leave learners solely with cadavers. To elevate the quality of anatomical education, truly that is the foundation of the clinical practice. We train the students, no training, no training of anatomy, no surgical training. So we have to elevate the quality of anatomical sciences education on par, as we are asked to complete the CBME on par with USA and UK. We have to get the resources on par. This is the need of the hour. These are the reference links of various teaching methods used in various Western universities. Thank you all for your patient hearing. Any doubts I can help.